Welcome to KRA's The Hub, the official podcast of KRA Corporation. And now get ready to hear workforce topics and trends you need to know on the go.
Welcome to KRA's The Hub podcast. I am the host, Jonathan Overall, and it's in this podcast where we bring thought leaders in workforce development. We explore ideas, innovations, and stories of impact that are shaping the industry. Today is another episode in our Get to Know KRA series, and we're featuring one of KRA's long-standing partnerships with Clarent, a healthcare consulting and quality improvement organization. Now, KRA is partnered with Clarent in leading and providing performance reviews for Maryland's Medicaid program. And to dive into this topic further, I'm joined today by Kathy Koontz. She is the consultant with KRA working in partnership with Clarent. Kathy, welcome to the Hub.
Thank you so much. I appreciate being here.
Now, we're going to talk about a number of different things related to the work that you're doing, Medicaid, even some things that are current that have recently come through federal regulations. But let's talk about your background and your journey professionally with KRA and as it's related to this project with Clarent.
Okay. I have a really diverse background, all healthcare related. I've been in the industry over 40 years, and I have worked in over 25 states. I've worked with all age groups across the age and service delivery continuum. I've worked with physical health, behavioral health, special needs populations in particular. I worked with probably most federal agencies like CDC. I've worked with SAMHSA. I've worked with HUD. I've worked with, many different agencies at the federal level and at the local level. I kind of started this whole journey as a nurse. I got my degree from the University of Maryland in nursing, and I went to work at a 250-bed med-surg hospital in Lanham, Maryland. And over that period of 14 years working there, I had a variety of roles as a nurse. I was an administrator at night while I went to graduate school, got my nurse practitioner certification, did employee health there, and subsequently worked in planning and research, marketing, strategic planning. I was over medical staff services. I developed a lot of programs internally. But what was really instrumental in getting me to where I am is that in the day, when I got my nurse practitioner certification, nurse practitioners were not well received in the Washington, D.C. area. Just by chance, the CEO of the hospital I was working in, we were part of a Fortune 500 healthcare chain, and they were looking to have a team, 2 beta sites, research sites to redesign hospital delivery systems. So they asked me to coordinate a team of 12 people in our hospital, and then there's another site in Texas. But they asked me to coordinate this team, and I said, I just finished graduate school. I can't do this. And they convinced me that this was a great opportunity. So I was part of a team that was looking to stop unnecessary procedures, to basically shift activities to people that were more appropriate, like nurses shouldn't be doing runs to pharmacy and that type of thing. And then we had we were looking to streamline processes, like how many forms does an individual have to fill out to do any number of things. So by doing that, it really opened up my eyes to the fact that there's so many process improvements that are an opportunity, especially in the healthcare arena. So I was a corporate consultant for a year, and then they laid off the program, and I moved to a think tank in Baltimore, the University of Maryland, Baltimore County. And that was when I helped develop the Medicaid program for Maryland. I helped write regulations, and I wrote the operational policy and procedure manual that went to the federal government. And at that time, they viewed that as a model for other states. But that was, like I say, a long time ago. When I left there, I came over to KRA to help develop a health practice there. And I stayed there for a couple of years. And as the organization began to move more into the workforce development arena, I thought it might be a good idea to start my own business. So in 2000, I did that. And I've worked, like I say, across many states. And my real expertise is in the Medicaid waiver arena with states and also in children's mental health. I did 17 years evaluating children's mental health programs. So that's all culminated to where I am today, that as part of that KRA team, we had a relationship with what was Delmarva at the time and is now Clarent. And I carried on that relationship as a consultant with KRA since 2000. And I've been working with the state of Maryland and other states on their external quality review organization activities. And so that's put me with KRA and Clarent for the last 25 years in Maryland.
To help our audience connect the dots, what is an MCO and what are some of its core functions of service?
Okay. Managed care organizations are contracted by states. In Maryland in particular, Maryland operates under 1115 waiver program, which is basically mandatory managed care. There are exclusions for rare and expensive care conditions and things like that, but over 1 million people are within the Maryland Medicaid program. So managed care organizations provide or basically enroll individuals and are accountable for outreaching to get them into care and primary care services. Every MCO has assigned a primary care provider to that individual. They're accountable for credentialing providers. They're accountable for all the privacy requirements. They engage in individuals into care through care. Those with really chronic and most vulnerable populations get a care manager who helps them navigate the service system. But the primary focus is to ensure that people are getting access to necessary preventive healthcare services and chronic healthcare services so that they can have better outcomes. And a lot of the Medicaid research has shown that with the expansion of Medicaid across the country, there is really solid research that shows that the outcomes for these vulnerable populations have improved significantly.
Now, you've seen Medicaid evolve over the years in healthcare. When you look at some of the changes, and there are some things that are coming soon in 2027 that are going to impact both the recipients of Medicaid and also the organizations that are providing these services. Describe for us the significance of the moment that we're in when it pertains to Medicaid and the organizations and recipients.
Okay. Historically, back in the 1960s, when it first started, Medicaid has been a safety net, if you will, for families, low-income families that predominantly focus on women, pregnant women, and children. And over the course of time, through the last several years, numerous decades, the focus has been on expanding Medicaid and upping the federal poverty limit so that more and more people can access services. And through having done that, there are almost every child in the country is covered under what we call the EPSDT program. It's diagnosis and treatment for kids that have any medically necessary services that they should receive those. So now when we are faced with what the Trump administration refers to as the One Big Beautiful Bill Act, which was signed into law in July 4th of 2025. What this will do is drastically change the focus of Medicaid and reduce the expansion. They're predicting that it will make about $1 trillion in cuts to federal healthcare programs. That includes both Medicare and Medicaid. And specifically for Medicaid, states are looking at about $940 billion in program cuts. So states and the federal government, Medicaid is basically a partnership between the federal government and states. And states get a match for when states were asked to expand Medicaid, they were given a higher match. So in other words, 90% of the funding would come from the federal government and 10% to the states. So what's happening and what this means for managed care organizations, recipients, and states is that the there are, beginning January 1 of 2027, these changes are going to reduce the amount of funding that the states receive, and which means that there'll be less dollars for programs and services like that address social determinants of health, like food, housing, transportation. The Congressional Budget Office estimates that 12 million people will be uninsured by 2034 because of this bill. Some specific areas that are affected that I think will be important to your audience is that the eligibility redetermination timeframes will change. States will have to check Medicaid eligibility every 6 months instead of once a year, especially for the expansion states. Enrollees will have to be doing some cost sharing. I think it's $35 per service for those with incomes greater than the federal poverty limit. There'll be bans on new provider taxes and a reduction in provider net revenue. And the importance of this is that provider taxes are what states use to fund Medicaid programs. Medicaid payments for migrant health services, including emergency care, will be banned, which is a huge, huge thing for the workforce, especially for migrant workers, many of which are, working in our country. Another huge shift that's really critical for the workforce development arena is that there are Medicaid work requirements now attached to eligibility determination. So the determinations will be tightened, and Medicaid enrollees will have to verify work. And what work requirements are specific to that 19 to 64 age group. And this means in order for an individual to be eligible for Medicaid, they must show proof of 80 hours per month of what is called community engagement. I think of community engagement in terms of outreach, but in the context of this law, community engagement means paid work, community service, or being involved in an educational program. And it's anticipated that 18.5 million people will have to prove they're working under this new regulation. Validation of the work requirements has to occur within 1 month prior to application and within 1 month of the 6-month renewal period. So you can imagine the changes that would come about in terms of processes and the fast pace at which changes must occur across all these different stakeholders, especially when this starts 6 months from now in January of next year. It's important to know that more detail on this is coming, and I'm certainly not an expert in this area, but I am familiar with the regulation components and what I think the effect has on the different stakeholders, as I mentioned. But the other thing that's important here is that if a community engagement requirement is not met, then individuals will not be able to access the insurance marketplace and will be subjected to cost sharing and increased insurance premiums. But there are some exemptions, and I think this is another area where the information systems that track this kind of data will be critical. Exemptions from work requirements include children under 19, youth in foster care, former foster care youth up to age 26, individuals that are eligible for both Medicaid and Medicare programs would not be under this requirement. Blind and disabled, pregnant women, individuals with substance use disorder, disabling mental health conditions, physical, developmental, intellectual disabilities. And the one thing that jumps out at me is what they call medical frailty. And this is serious medical conditions. And the challenge with that piece of the legislation is that it's another barrier because individuals aren't allowed to attest that they have a medical frailty. They have to show proof. And this is a challenge because there's not a procedure code or any kind of way for an individual to identify if someone's too sick to work. So this is another bit of quagmire, if you will, in terms of setting up the processes around these regulations. So as you can imagine, there's a lot of changes that will affect every aspect of managed care organizations and at the state, and then for those recipients that are either actual or potential members, enrollees in Medicaid.
With some of those changes, particularly the work requirements, what opportunity do you see with clients and MCOs working closer, more aligned with some stakeholders, as you mentioned, that are in the workforce community?
It's going to be critical. I think one of the huge things for me is that, we typically think of strategic planning as long-term planning. And in this environment, strategic and fiscal planning are going to be really real time and not long term. I think states and managed care entities and community-based partners, especially, I think a communication plan is going to be critical so that all parties know what their roles and responsibilities are. This is a huge issue in and of itself in most organizations that deal with multiple stakeholders. And I'm a big proponent of, if you know up front what the roles and responsibilities are, there's less fragmentation or potential for it, and that people don't fall through the cracks when there's a clear understanding of those roles and responsibilities. In all my years working with managed care organizations, I think access to care and gaps in preventive care are some of the biggest operational challenges. So in the context of people going on and off Medicaid rolls, it just adds further barriers to for people to comply to all of these different requirements. The term enrollment churn is often used, and it will be a huge outcome of the redetermination process, so that different aspects of decision makers for care management, finance, all that kind of thing will be really a challenge to try to manage all of those things. So those relationships, especially community-based organizations, that if their funding is cut, then what does that mean for the individual? The funding sources, if they dry up, I mean, this potentially could have Medicaid managed care organizations exiting from Medicaid and Medicare. This could potentially reduce programs that support food deserts and, all the social determinants of health. So the people that are supporting and working with these individuals to get them into these environments, again, it's how do we do it? Are dollars going to be shifted from one program to another? And then when that happens, cuts happen. So who makes the decisions on priorities for, who gets what funding for what services?
You hit on the key point there, which I believe is the connection with workforce and awareness. And you mentioned communication, and I'm sure that probably is in the workflow of the services that are provided directly to the clients, ensuring that there's communication and also probably collaboration with workforce providers to ensure that they're receiving the support so that they can meet those eligibility requirements that involve work.
And, the communication component to me is the educational and outreach strategy as well, because everyone has a role. Managed care organizations, the states, workforce development organizations all have a role in being the point of reference, or the contact point, if you will, for enrollees. And so they need to be educated on what these requirements are and the nuances of what it means to the enrollee. If we think about everything from the enrollee lens, or the individual lens, what is it important to them? What are the barriers for them to be able to access these programs? And I believe that piece of it is also that, that whole outreach and education to all the access points is critical, because if individuals are given incorrect information, it just prolongs the process. And the other thing that I think is going to be really critical is in developing all these information systems and data systems. And I'm not sure how that would affect, Jonathan, how that would affect workforce development organizations. But there's an opportunity here, in my mind, to be able to upfront put all these exemptions into a data system and do all of the upfront work, and not have to follow up with people, which is a huge part of Medicaid access, is that constant follow-up. If we can get it right at the front end, then and identify the exemptions, then there'll be less denials of Medicaid applications and more people getting access to the services they need. So that's kind of another piece for me that's going to be real important.
Let's talk about KRA's role, the specific work that's taking place. I know it involves data analysis, auditing, monitoring functions, and continuous quality improvement strategies. Can you talk to us about what that actually looks like in practice and how it helps strengthen the healthcare system?
I think it's important first to understand what when states that receive federal funding are required to have an external quality review organization assess the compliance to state and federal, or particularly federal regulations, if the federal government is providing that match, funding match. So for KRA, Clarent is the external quality review organization that we work with. There are two consultants, myself and another individual, and we're in a process now of trying to have a KRA position established to assist me in this process so that there's some continuity. I'm getting toward the point that eventually I'm going to retire, and so I need to ensure that there's a team that can follow. But anyway, so KRA works with Clarent in developing the standards of care that will comply with both the state and federal regulations. So we look at, the first and foremost thing we do is we read the federal regulation, we read the state regulations, we read the contracts the MCOs have with the states to really understand the intent of the standards that we're evaluating. I think one of the things that's often missed is when you interview people is if they really understand the intent of the program and of the processes that they're in charge of or accountable for, if they can articulate that to me, but they don't have a policy and procedure in place, the policy and procedure can be changed quite easily, but it's that knowledge. So we help them understand the intent of these regulations in the context of credentialing, in the context of outreach, in the context of provider network development. In Maryland in particular, the Code of Maryland regulations is very detailed. Most states, if not all, have their managed care contract and standard requirements into their contracts. Maryland is very unique. Maryland has the Code of Maryland regulations. Everything about what needs to happen is written in regulations. So in Maryland, you have to follow that regardless. So we help them understand the policies and procedures. So we look to see that their contracts are in alignment with all the state and federal requirements. Once we get that background information, we don't need to do it again unless there's a new health plan added or new changes to regulation federally, state-wise. We often will assist the state in conducting a readiness review to determine if that health plan is ready to go up and get up and running to accept enrollees. So everything we do is guided by federal protocols. There's 6 different protocols that we are aligned with. One, some of them have to do with enrollee rights, some do with grievances, appeals, and denials, some have to do with all the different Medicaid operational components. And we don't do anything finance specific. Those are left to insurance regulators and certified public accountants, et cetera. But there are 3 things that I look for when I work with a health plan. Based on all these standards that we have to review, do they have policies and procedures in place that align with those standards? Do the MCOs, managed care organizations, implement these policies and procedures as written? And are there methods for assessing the outcomes for those processes? So if it's a new health plan, there won't have outcomes, but having 25 years of experience with the state of Maryland, there's some evident improvements that have taken place. And I think, we have a history to know where things have evolved. And the biggest issue is turnover. If there's turnover within the health plans, new people come on and there's tending to be lack of compliance just because they don't understand. So our role is to help them get up to speed and provide consultation, especially for all the new changes. We try to give our input as to experience in other states and what's happening, and maybe support new initiatives or innovative strategies by that presence of knowledge of other states.
What is KRA's approach to go from compliance in meeting those requirements to helping an organization truly embrace continuous quality improvement?
I think one of the things that KRA does, the consultants for KRA do best, is that we approach these external quality review organization evaluations. I call them evaluations. A lot of people call them audits. Audits to me are finite. Evaluations offer opportunities for improvement and change. We approach the health plans in a strength-based approach and not a punitive one. And I think we have success because we look at it, even though professionally we can be very objective. We want the health plans in the states to view this as a collaborative relationship, and that when we make recommendations and changes, they know we have their best interest and the enrollees. I mean, ultimately, we're all in this for the enrollees, and we constantly redirect the thinking to those enrollees and the effective changes and what these standards mean in the context of the services. So we look at quality assurance, very different than quality and process improvement, which is different than continuous quality improvement. So if a performance meets a requirement, but there's not any sign of a systemic change, then we make a recommendation. So for example, one of the things that we do that drives everything is the state. We expect the health plans to have a population assessment, and that's demographics, that's geography, that's top 10 health conditions in ER, inpatient, outpatient, pharmacy. And we use that to dictate what we look at. So for example, if the state and the federal government say you have to provide preventive care to children under 21, fine, that's a mandate coming from the state. I look at the data. If there's a large population, for instance, especially in Maryland and Prince George's County, where there's a higher African-American population, if I see a large population of enrollees with sickle cell anemia, but I don't see any programs or services associated with that condition, then I raise that, because it's a red flag to me that you have to know the population you're working with, not just what agencies state you have to do. You really need to know who you're serving and the barriers that they face to access. And especially now that there's such a movement on the side of disparities in healthcare and the social determinants of health. And I worry that we've made such inroads with improving, identifying racial and ethnic disparities and working to try to improve language and interpretation services, et cetera. I worry that those things are going to go away with all of these funding cuts. So anyway, that's kind of one of the things. We look at data trends and see what occurs from year to year, whether metrics are moving in a positive direction. And we use the interview process to delve further into kind of what's being done to make improvements. And if we don't see that, we will provide our recommendations again and input that might be happening from another state. The other thing that I think is really important is that we have 9 health plans in Maryland that KRA is consulting for. And we have the opportunity to look at data in the aggregate. And when you go from health plan to health plan to health plan at the end of the review cycle, you start to see patterns of things that are occurring. So whether they're positive or negative, we share those with the state. And in every report, we're always focusing on the strengths of the organization as well as opportunities for improvement. But again, our approach is we want you to consider X, Y, and Z. We don't tell the plans what they have to do, but based on our experience, I think that in all the years that I've worked with the plans, I think our findings and recommendations are really valued, and that there have been some significant improvements over time. And the other thing is that, we make mistakes, and there are times that the health plans will challenge our findings, and we work with them and to try to come to a solution that's amenable to everyone. And we had a health plan contest a finding the other day, and I agreed with the plan. So it works in their favor. We always tell them at the beginning, our job is to make you look as good as possible, to show what you're truly doing. A lot of people don't tell the story well, but we can really see that these people work very hard to try to make a difference in the people they're serving.
Kathy, you've given us deeper insight today on this area of Medicaid and managed care providers, and really walked us through the insights of the current condition of the industry, especially with some of the changes that are coming, the approach to coming in and providing not only monitoring and analysis of data, but also how you can translate that into improvement. And with the backdrop of uncertainty of the future and changes coming, in closing, what would you say you're most optimistic about the future of services to clients in the area of Medicaid?
I'm always a glass half full person. So I always try to find things that I think will make a difference. And with my background on process improvement, I really think that this could be a great opportunity for this bill to expedite some of the information technology changes that have really been lagging across the industry and ultimately reduce administrative burden on enrollees, on care managers, on providers, on states. I think the advent of artificial intelligence and its appropriate use, I say appropriate use, may lead to process improvement. And I think that the focus on these rapid changes in eligibility data systems, et cetera, there's an opportunity to really focus on what users need and not on what the systems can do. We often forget. It's like, okay, this software platform can do X, Y, and D. Well, what is it? What do we need to do for the user to make the application process more friendly? And again, reduce the amount of denials. And we also have to think about overlapping processes. And one of my kind of mantras is that managed care processes are the same no matter what you're doing, whether you're in Medicare, whether you're in Medicaid, whether you're in employee-based commercial insurance. Processes for managed care, like quality, like utilization management, all of that doesn't change. What changes and what's critical is the network. Do you have appropriate providers to serve youth populations, older adults? Are there neonatal specialists, obstetricians to deal with pregnant women? So these kind of things, I'm hoping, will create more of an integration of not only compliance metrics, but the ability to reduce all this extra paperwork. I mean, I always say, if I'm doing my job, I won't have one, because ultimately you want people to be able to do things as streamlined as appropriate so that people don't fall through the cracks. They get the services and they have the positive outcomes. And so I really think that we could reduce much of the oversight processes that are separate from Medicaid, Medicare, employees, et cetera. So that's my take on it. And I really do think if we can work together across all the different groups, we can have a really positive outcome, especially in the processing pieces and the duplication of services or reduction of those.
Well, I think that's a call to action, and I think that's a great opportunity for our audience to hear more about this topic in Medicaid. And so I want to thank you, Kathy, for bringing awareness to that and also highlighting what KRA's role is within this field and partnering specifically with Clarent. And if you're listening in our audience today and you would like to learn more about what KRA is doing in the consulting and the healthcare industry, you can go to our website at www.kra.com, and under consulting, we have a contact us tab where you can learn more information and talk to one of our team members to discuss the opportunities here in partnership and continue to talk about the impact of the work. Well, Kathy, I want to thank you for joining us in the Hub today.
Oh, it's my pleasure. I really appreciate this opportunity. It makes me think. It gives me a lot of food for thought. So I really appreciate being part of this.
Well, we'll continue to follow the work that's being done as well as what's happening in the industry, and wish you all the best. Take care.
Thank you so much. You too.
Thank you for listening to KRA's The Hub. Don't forget to subscribe to the podcast on Spotify, Apple Podcasts, or wherever you listen to podcasts. To learn more about KRA Corporation, visit www.kra.com. Thanks so much for listening, and we'll be back soon with a new episode.